percutaneous sonographic guided tips in 103 patients with Budd-Chiari syndrome. I have no financial disclosure to declare. Budd-Chiari syndrome is a hepatic vascular disorder with venous outflow obstruction at any level from small hepatic veins to the junction of the IVC with the right atrium. This causes venous stasis and congestion, which leads to central-lobular fibrosis, nodular regenerative hyperplasia, and ultimately liver cell loss and cirrhosis. And so it is a benign disease, however, it is a fatal disease if not treated. TIPS is proved to be an effective technique in the treatment of patients with Budd-Chiari syndrome because it bypasses the venous outflow obstruction and decompresses the congested liver. As we know, the most critical step in TIPS placement is gaining access to the portal vein. And in the classic transjugular TIPS technique, the patency of the hepatic veins facilitates this technique somehow, as we catheterize one of them and do the puncture to the direction of the portal vein. However, this is not the case in Budd-Chiari syndrome because we have occlusion of all hepatic veins. And in this case, we are obliged to do the puncture directly from the IVC to the portal vein. And although TIPS can be placed in patients with Budd-Chiari syndrome using the classic transjugular TIPS technique, however, this needs much time, much effort, more trials to puncture the portal vein, maybe more complications due to the more trials, and also with longer fluoroscopy time. So in our institute, we prefer to do the modified percutaneous sonographic guided TIPS technique. And the purpose of our study is to present a single center experience in evaluating feasibility, efficacy, and safety of modified percutaneous sonographic guided TIPS technique by direct simultaneous puncture of the portal vein and IVC in Budd-Chiari patients. This is a retrospective study. Between May 2006 and May 2012, modified percutaneous sonographic guided TIPS technique was performed in 103 Budd-Chiari patients, 62 women, 41 men, ranging in age between 11 and 55 years. Indication for TIPS was resistant ascites and GI bleeding in 86 and 17 patients respectively. This movie shows us how to do this technique. Actually, in this technique, we don't use the whole TIPS set, we use only the long 10 French sheath, and this actually saves about $600 per procedure. We do a jugular puncture, insert the long 10 French sheath in the retrohepatic IVC, and then we introduce a dormia basket or snare inside this sheath. Then we do the most important step in the technique under ultrasound guidance. We do puncture of the right portal branch here by 18 gauge needle. This is the tip of the needle. And once we do the puncture, we inject contrast to confirm the location of the needle tip. Here we are inside the right portal branch. After that, we do double puncture of the right portal branch to create the track between the right portal branch and the IVC under real ultrasonographic guidance without the need for fluoroscopy. This is the tip of the needle directed toward the IVC. And once we puncture the IVC, we introduce a guide wire through the puncture needle to be picked by the dormia or the snare into the long sheath. And we get this guide wire outside the sheath, so we have one end outside the sheath from the jugular puncture and the other end from the abdominal wall. After that, we dilate the track between the IVC and portal vein by 8 mm balloon. We dilate first at the side of the portal vein. This is the waist at the portal vein wall towards the IVC, and should be cautious to dilate only one wall, not both walls. Then we pull the balloon up to dilate at the side of the IVC. This is the waist at the IVC wall. Then the balloon is completely inflated. So the tract is dilated and we advance the sheath down to the right portal branch and do portography. We leave after that this guide wire in place and then introduce another guide wire into the sheath from the jugular side and manipulate it into the main portal vein. So this technique may be also called double wire technique. And then we advance a manipulation catheter over the guide wire into the portal vein to do portography. Then we advance the sheath into the main portal vein, followed by the stent inside the sheath, and we will draw the sheath up to deploy the stent from below upwards. In our center, actually, we use the pair wall stents due to economic reasons. Here the stent is deployed. And after deployment of the stent, we do dilatation by 10 mm balloon to give the stent its maximum diameter, considering the shortening which occurs in the wall stent. Ensure we measure the pressure gradient before and after the stent deployment. Then this is the end result. After the procedure, we do frequent hemodynamic monitoring during the first 24 hours for fear of bleeding, which is the most common complications. We give anticoagulants immediately after the procedure. And we keep these patients on oral anticoagulants for life to adjust the INR between 2 and 2.5. Duplex ultrasonography is done at day 1, 7, 30, and then every 3 months for early detection of any-stent dysfunction. We achieved technical success rate of 99%, only one case of failure, and this was due to bleeding during the procedure, so we didn't continue the procedure and refer the patient for surgery. We achieved a reduction in mean port systemic pressure gradient from 21 to 7.5 millimeter mercury. Rate of primary patency was about 68% at 1 year, and rate of assisted patency after re-intervention was about 90% at 1 year. Concerning the clinical outcome, 84 patients show excellent response to TIPS procedure concerning regression of the varices, stoppage of bleeding, and disappearance of ascites without any medication. 11 patients were presented before the procedure by refractory ascites not responding to maximum dose of diuretics. However, after the procedure, the ascites disappeared on regular dose of diuretics and the patients were satisfied, so we considered them as successful cases. Only 8 patients didn't respond to the TIPS technique and were referred to do liver transplantation. So we achieved a clinical success rate of about 92%, overall survival of 91%, 5-year survival of 86%. We have 9 major complications, 3 cases of mortality, and actually this was early in our learning curve. 3 cases of controlled intraperitoneal hemorrhage, 2 cases of controlled hemorrhagic pleural effusion, 1 case of controlled pulmonary embolism. 2 limitations in this study. The first one, we didn't use a PTFE covered stent due to economic reasons. The second one, no control group to compare with the classic TIPS. To conclude, modified percutaneous sonography guided TIPS by direct simultaneous puncture of portal vein and IVC is a feasible, effective, and safe technique in butt carry patients. Excellent technical and clinical success rates with shorter fluoroscopy time can be achieved by this technique besides its economic aspects. Further studies comparing the outcome of this modified technique with the classic TIPS technique are needed. Also, we need studies comparing between the cost effectiveness of pair stents and PTFE covered stents. Thank you.
It's very interesting paper. Any questions? I'm sure there'll be plenty of them. Yes, please.
You mobilize the percutaneous tract in the liver?
Yes, sure. Yes.
And with glue?
No coils.
With coils. And what the duration of that anticoagulation? Due to the underlying disease, or in all cases you use anticoagulation?
In all cases, we use anticoagulants and for life.
Good management.
Excellent. I was really impressed with the skills and everything. Why do you use 18 days and not like a Shiba?
Actually, it makes no difference because I embolize the thread. After I do the technique, I embolize the thread. So there is no fear of behavior.
Obviously, I think it's more steerable, you can see it better, but you think it makes no difference?
Yes. Maybe
What wire do you use to snare?
Sorry?
What wire do you use?
What
Do you use a Peruno wire or
do any type of snare or dormelastic video? No difference.
He's asking which wire do you use to enter? Is it a
Yes,
hydrophilic
we
wire?
use certified wire, and I start immediately by introducing the stiff wire from the abdominal side.
Amplifiers.
Ambulances, yes.
Yes, there was another question. Nice talk, thank you. Why is there a particular reason to choose to puncture the IVC directly and not go for the deficient approach? That you can also see less an ultrasound guidance, and maybe you don't have to go out of the liver and get an additional complication.
First, these butt carry cases, we do TIPS when the hepatic veins are occluded. There is no patent hepatic vein.
Completely until the
Completely or partially, but we cannot do puncture of the hepatic vein. It will not be useful for these patients. There is a long segment of occlusion or completely occlusion, so we cannot use the hepatic vein to do this TIPS procedure. So we do direct puncture of the IVC, and actually there is no fear of bleeding from the IVC puncture. All cases of bleeding were from the portal vein puncture, because the IVC we do puncture at the retrohepatic portion is protected by the liver.
I heard sometimes that you also puncture inside and include it, but we are sometimes by standing it can also go
Thank you.
Right, Dr. Shaker, one last question is, the video you showed us was a patient didn't have ascites. Now, almost 80% of them actually have significant ascites. Now, is that a problem when you're doing the ultrasound guided puncture? And secondly, is that does that also contribute to an increased risk of bleeding? I realized 6 patients of yours had a large amount of bleeding.
Yes, actually for shortage of time, many data I didn't mention in my study. But actually I do routine tapping of the sites before this procedure to make the liver fixed and thus facilitating the technique. And second point, tamponade of bleeding. Yes, thank you. Routine tapping.
Thanks. Okay, thank you, Dr. Shaker.